Hello, my name is Gabriel Soriano. My teacher is John Moscoso. My topic is safety and efficacy of bemzoic acid to reduce LDL cholesterol. First, introduction. Short-term studies have shown that bemzoic acid, an inhibitor of ATP citrate, reduce level of low-density lipoprotein cholesterol. There are limits regarding the safety and efficacy of benzoic acid treatment in long-term studies involving patients with hypercholesterolemia who are receiving guidelines recommending statin therapy.
Statins are a group of medications that reduce cholesterol levels. They were discovered by Akira Endo in 1971, a Japanese biochemist. There are several statins in the market currently, which are very easy to remember because they all end with the suffix statin. Cholesterol is produced by the liver and transported by lipoproteins, which consist of two types: low-density lipoprotein, which is known as bad cholesterol. Its main function is to transport cholesterol throughout the body. The other type is high-density lipoprotein, also known as a good cholesterol. This type of lipoprotein removes the excess cholesterol and carries it back to the liver for degradation. So how does it work? Statins work by competitively inhibiting HMG coenzyme A reductase. This enzyme catalyzes the reduction of HMG coenzyme to mevalonate, which is the rate-limiting step in hepatic cholesterol biosynthesis. Inhibition of this enzyme decreases the cholesterol synthesis, leading to an upregulation in LDL receptors in the liver. This increases LDL uptake by hepatocytes, decreasing the amount of LDL cholesterol in the blood. Who should statins be given to? According to the American College of Cardiology, statins are given as a prevention of cardiovascular diseases in patients with LDL cholesterol more than 190 mg per deciliter. On average, statins can lower blood LDL by 70 mg per deciliter, which translates into an estimated 60% decrease in the number of cardiac events like heart attacks or sudden cardiac deaths. Contraindications of statins. Being drugs that are metabolized and excreted by the liver, statins are contraindicated in cases of chronic liver disease or elevated serum transaminases. Statins are also not given in pregnancy or lactation as they are in category X. Lifestyle modifications are strongly advised in patients on statins. These modifications include less caloric intake, low animal fat diet, and physical exercises. Monitoring creatine kinase is important in patients taking statins, as myopathy is one of the most common and dangerous adverse effects of this class of medications. Thank you guys so much for watching the video. If you
Application in medicine. We can do a randomized controlled trial involving patients with atherosclerosis, cardiovascular disease, heterozygous familial hypercholesterolemia, or both. Patients had to have an LDL cholesterol level of the last 70 milligrams per deciliter while they were receiving maximally tolerated statin therapy with or without additional lipid-lowering therapy.
Number 8. Bempedoic acid for cholesterol lowering in statin-intolerant patients.
High cholesterol is a major concern for nearly 40% of American adults. The fat-like substance is necessary for the body to function, but too much low-density LDL cholesterol can lead to buildup in the blood vessels, which can cause a heart attack or stroke. While several medications exist for treatment, statins are the most popular, but the prescription comes with some adverse side effects. Statin drugs enter muscles, causing muscle pain in approximately 5 to 10% of people who take them. A new agent, bempedoic acid, has been designed as a once-daily oral therapy, given in addition to a patient's current cholesterol medication regimen. Like statins, bempedoic acid works by blocking a key enzyme used by the body to make cholesterol. But unlike statins, it cannot accumulate in muscle, reducing the likelihood of muscle pain. In clinical trials of the therapy, patients saw their LDL levels drop by an average of about 25%. If approved by the FDA, bempedoic acid could be another addition to the arsenal of cholesterol-lowering treatments available to patients.
Pros and cons. Pros. Lipid-lowering therapy, primarily statins, have substantially reduced the burden of cardiovascular disease over the past decades. Cons. Statin therapy alone is often insufficient to achieve proper lowering of the low-density lipoprotein cholesterol level.
This year about bempedoic acid as it's come out in a series of studies. They're all clear wisdom, clear harmony, but they are basically safety and efficacy studies looking at the efficacy of bringing down LDL, looking for adverse events, and there were more secondary outcomes around clinical metrics like mortality and cardiovascular events. So the drug was effective in lowering LDL, and in that regard was done safely. The intolerances were mild, and I think they proved that LDL levels can be adjusted with this. They actually looked at it in a variety of populations, those who are statin intolerant, those who are on maximal tolerated statin, those on Zetia or in adjunct with Zetia. So they really were trying to get that mix of populations where it could be applicable. But they haven't really shown the kind of data we need for it to really replace statin therapy. The mortality benefit we've seen over many years from statin therapy, it will be hard to beat. But it is true that we have a lot of people who are statin intolerant, and I think that this will offer a viable option. And you can't have this conversation without the PCSK9 inhibitor category, which had effective LDL lowering and improvement in cardiovascular outcomes. But again, on top of either a max tolerated statin and Zetia or a familial hypercholesterolemia pattern. So again, these are often taking into account a background of existing high quality therapy. So I think the mechanism of action of the drug is very promising. I think it is targeting a community that is underserved right now, which is those who may be statin intolerant or need additional therapies despite their statin. So I think it will fit in to the paradigm. I think statins will probably remain the first-line agent for all, but for those who are intolerant or insufficiently managed, this bempedoic acid could be added on. It's likely to be more favorable than an injectable. PCSK9 inhibitors are injectables, and that can be a difficult regimen for people to adhere to. So in having an oral agent that you can add in daily that may come in at a more affordable price point, I think will give a lot of us in cardiology, and I think for physicians across the board, to think about this as a therapy for our patients who need LDL lowering. But again, there's more data to come. We haven't seen all those hard outpoints yet. likely to have some data in that space in the coming years, but I think until we see that, you're not going to see a big paradigm shift. But I do think that we'll be thinking about it for those patients who are having intolerances, because we have seen that LDL lowering has been favorable. The drug itself didn't have any major adverse events of concern and seemed largely tolerable by those who are in the study. So I think we have a window opportunity to take advantage of this mechanism of action, which is a little different than statins and PCSK9 inhibitors, which will allow perhaps for some more complementary use of drugs and really targeting different patient populations. So it seems promising, but I think we need more information before making a complete paradigm shift.
Conclusion. In this 52-week trial, bempedoic acid added to maximally tolerated statin therapy did not lead to a high incidence of overall adverse events than placebo and led to significantly lower LDL cholesterol levels.
Clearly, the benefits of statins are really to reduce the risk of major cardiovascular events. So heart attacks and strokes are certainly related to high cholesterol levels, and optimization of those levels with statins have been shown to reduce the rates of these types of events. So we talk about sort of the benefit of lowering the risk of having a heart attack or stroke by 30 or 40% versus the potential harm, which are these things that we've talked about. And in general, most patients, once we discuss sort of the relative benefits versus the harm, then most patients, I think, are willing to at least try to treat their cholesterol with medication. Patients have different side effects to different medications. So just because they have a side effect to one statin doesn't mean that they're going to have the same side effect to another statin. So frequently we can change the medication and the patients don't experience the same side effect with the medication. If they have some resistance, then we talk about focusing on the things that they have control over, which is diet, exercise, those things that they can control, and then potentially reassessing if their cholesterol levels improve before necessarily just requiring that or recommending that they start medication up front. I think part of it is really allowing the patient to sort of express what their concerns are and what they've read on the internet or through other sources. The reality is that a lot of that information is probably not really carefully reviewed. Part of my job really is to educate the patient on what data is really accurate or reliable versus information that isn't. And that way we can have, I think, a good discussion about the risks and benefits of taking medication to treat their cholesterol.
Thank you for paying attention.